Hi, everyone, and welcome to everyone joining us. I'm Dr. Effie Andrikopoulou, the Medical Director of the Echo Lab at Harborview Medical Center in rainy Seattle today. And I am honored and so excited for the opportunity to moderate this webinar organized by the American Heart Association Center for Health Technology and Innovation. And we're going to be focusing on how technology is changing cardiovascular monitoring and diagnostics. I am thrilled to be joined by this amazing and very well accomplished group of panelists with me today. We have Oliver Piepenstock, who is the co-founder and CEO of NOAA Labs. We have Don Fowler, the president of Echo IQ USA. And we have Dr. Daniel Cadillon, the Chief Medical Officer for Masimo. Our goal today is to discuss how innovative and emerging technologies are reshaping the way we monitor health and diagnose disease. We will share real-world applications, the latest breakthroughs, and lessons learned on how we can improve outcomes, increase access, and optimize efficiency across the healthcare continuum. So without further ado, I'm going to first say hi, everyone. It's great to have you all here. And I know we're going to have a very productive conversation today. Let me jump right in and start with, maybe I can start with Oliver. Oliver, as clinicians, we are overwhelmed with fragmented, siloed data and notifications fatigue, alerting fatigue. How do you think innovative tools and emerging technologies can change and reshape diagnostics and testing in a way that reduces clinicians' burden instead of adding to it?
Yeah, thank you, Effie. That's a great question, and I think this is the age of AI. Like we see this in many realms apart from the medical field, but now also in the medical world. And I think the huge opportunity here is the massive data AI can suddenly analyze, and in that way make diagnostics and monitoring a lot more accurate. So driving down false positives and driving up the sensitivity in really detecting the cases that are relevant. I think that's like the broader scheme that we observe by just factoring in more and more data points, from EHR data to remote monitoring kind of data, which is our domain at NOAA Labs, but also lab data, putting that all together and making sense out of it, and that way reducing false alerts and alert fatigue on the clinician side. I think this is like a major leap forward that we're seeing at the moment.
Thank you. Daniel and Dawn, would you guys want to add anything?
Sure. I guess I can go first, and Don, yield to you. But one of the things, I agree with everything Oliver said, and I would just say that on top of that is the importance of accurately capturing the human signal. I think, as physicians and hospitals, we're accustomed to a certain medical grade accuracy, sort of robust quality of our signal to make decisions. And as we enter this era of increasingly consumer accessible wearables, and we're looking to incorporate that data into our clinical practice, one of the challenges that we have, especially as we look to build increasingly sophisticated algorithms that are using AI, is we want to avoid sort of a garbage in, garbage out type of phenomenon. So I think that the technical standards are very important. If you're in a company like mine that specializes in non-invasive monitoring, that's really focused on optical sensors, that's our sort of our core of what we do as the global leader in pulse oximetry, but also thermistors, ECG, electrical sensors, gyroaccelerometers, accurately capturing out that human signal and filtering out the noise and the artifact is also very important, particularly as we look at false alarms and false alert detections. And then the other piece is just really the fit for purpose in terms of the algorithm. So an example of that is, getting away from the world of dumb alarms where, we're alerting in hospitals for heart rate high, heart rate low, blood pressure low, SpO2 low, and really more into disease detection. An example of that is, last year we got a clearance on an algorithm that maps to opiate-induced respiratory depression. So instead of alerting for, respiratory rate or SpO2, we're saying to the clinicians, okay, your patient is showing early signs of opiate-induced respiratory depression. So we think these kinds of smart alarms and smart alerts are going to represent the future.
Well, I'll tell you, it's not fun following you two gentlemen. You've done a great job summarizing this. The only thing I would add at this point is it comes down to building a sense and a community of trust with the clinicians, as you talked about, Daniel. What you do is very important and it's very personal to patients. So you have to trust the data, you have to trust the information that's coming out. So companies like ours and others have to make sure that the databases and the information that they're using to train these types of algorithms in the case of AI are some that have been validated, number one, and then number two, that can be understood. The notion of black box AI scares people, and rightfully so. We want to make sure that clinicians understand that we follow, like at Echo IQ, the same process that you go through as a clinician when you're making a determination on a phenotype for somebody. For example, in the case of structural heart disease and severe aortic stenosis, you start to build a phenotype as you're starting to evaluate this patient. Well, we do the same thing, right? We start to take a look not only at what's happening at the valve, but we also look at the entire heart. We look at the measurements that are happening in the atrium and the ventricles, and what's happening in systole and diastole, what's happening in the pulmonary function. And we take all of that information and we build out a phenotype of what we believe the disease could be. So in the case of severe aortic stenosis, we'll grade that as high, medium, or low. And it's a process that clinicians understand because that's exactly what they do. We just happen to be able to do this in a very reproducible way. We do so on an algorithm that was trained on millions of cases, and there's no fatigue that's involved. So I think it becomes contributory to what a clinician does on a daily basis, because let's face it, your jobs are getting harder and harder every day, and how technology can be impactful to making those jobs easier is, I think, why we're all here today.
Thank you, guys. 100% agree with all of the points raised. And to take us a step further, I would love to hear from you, and maybe we can start with Dawn. How do we do this? How do we build these trustworthy, reproducible, reliable, accurate tools in a way that represent everyone and in a way that truly represent the patients and the communities that they're meant to serve? Sadly, so far, what research has verified over and over again is that the risk stratification and prognostication tools that we use in our everyday clinical practice were not necessarily built and validated on the most diverse data sets. So I would love to hear from every single one of you. Maybe we start with Dawn. How do we ensure diversity in our data in, like Daniel said, so that there's accuracy in data out?
It's a great question, and it's one that should be first of mind for everybody. So actually, the genesis of our company actually started with a cardiologist that was looking at aortic stenosis and saying, how can we get better at diagnosing this disease? So the first thing that they did was take a look at what's the source of truth. How do we evaluate this disease? Typically, it's through an echocardiogram. So we're a company that was founded in Australia, and in Australia, we have a little bit different paradigm than we have in the United States. So they were able to build something called the National Echo Database of Australia and have access to millions of echocardiographic measurement data from across the country, across all the populations, to your point, and not just to segmented groups. And then interestingly enough, and fortuitous for us, is that information was also linked back to a mortality outcome. So not only did we have a database that was rich across populations and cultures, but we also then had some outcome data to support that. But again, because coming from Australia, you'll have countries like the United States and Europe saying, well, how does that validate across our populations? And for those who don't know, Australia is a very diverse population, but we did the same types of testing in the United States. We did a study at Beth Israel Deaconess Medical Center with over 31,000 patients of diverse backgrounds. Did the same thing in the UK. And then, of course, we went through an FDA validation process to confirm all of this. So I think you're spot on with the question is you have to make sure that we're not excluding any populations. What's interesting, however, is that we talk a lot about the biases that could be built into an AI, but we also know that there's unconscious biases that affect healthcare today without AI, right? And those they're unconscious, right? And some of those are gender and sex and race related. Some of them are hemodynamic biases or symptomology biases as well. And I think the use and the tool of having AI, especially in the case of just looking at measurements, begins to eliminate those biases and bring to light certain populations that in the past have maybe been underdiagnosed. In the case, I'll give you a concrete example. When we look at aortic stenosis, many of the cases that are underdiagnosed are the very difficult cases, right? It's the cases of low flow, low gradient, paradoxal low flow gradient cases. And consequently, they're also the way females present, right? So if these are hard to begin to diagnose, and now you've got a population that presents mostly in that form, it's understandable how, it's possible that females are underdiagnosed more so. So the tools that are employed now that just look at measurements, that just look at this at a higher level, can avoid those types of misdiagnosis.
Oliver, Daniel, I would love to hear from you how you think we can safeguard and implement diversity in development, implementation, and post-deployment monitoring of these tools, of emerging tools.
Yeah, thank you, Effie, for raising this point. I think it is absolutely crucial in the AI age to focus on diverse data sets. Because if we don't, the models tend to drift, right? And then they focus on a specific subpopulation, but not covering everyone or every possible outcome. And I think that's a risk. That's also a risk from an FDA perspective. That's something the FDA raises in pre-sub meetings. They want to see a really diverse data set. And that is not only the case in terms of the population in the sense of like age, gender, or socioeconomic aspects, but it's also like specifically for us at NOAA Labs, we focus on the human voice as a marker that we analyze. And in that regard, diversity also means that we need voice recordings that have been recorded with all sorts of different devices, like iPhones versus Android, but also different acoustic environments. A high ceiling room might have different acoustic features than a very tiny room full of carpets or something. Sound travels differently. So I think the diversity aspect, there's something generalizable about it, but there's also a specific component about each and every application that we see. And I think that's something we always need to factor in.
Yeah, I'll just add a real world example to the points that Don and Oliver made very eloquently, which is in our company's portfolio with pulse oximetry. During the pandemic, there emerged a very legitimate concern about racial bias in pulse oximetry. The idea was that, with darker skin tones, there's increased light absorption, and there was an overestimation of the patient's blood oxygen levels, and that could be dangerous if somebody was desaturating because the notification of the clinician would be delayed. So the answer to that really is both on the technical side and also on the algorithm development side. And so I just want to highlight some of the technical features that we believe are very important. So you have things like dynamic control of both the emitter and the detector when it comes to an optical sensor. So what we have in our technology is it can sort of scan, and it can measure the amount of baseline light absorption that you're getting through the skin between that path length of light, and you have the ability to amplify that, you know, in a situation where there's low perfusion, for example, as was mentioned, you know, I believe by Dawn, or increased light absorption if you've got darker skin tones. And so you have a gain control on the detector, but you also have dynamic control of the emitter, because somebody with my skin tone, you wouldn't want to use an excessive light amplification because you would oversaturate the signal. So there's a sophistication on the technical aspects. And I tell people it's kind of like, you know, if you drive a car with an automatic transmission, you don't think about necessarily you're changing gears. You just step on the gas and it goes, and you're relying on the automobile to make those changes, you know, due to what your driving needs are. So we have to make those types of really smart, innovative technological adaptations, you know, to some of these concerns. And then the second one is the one that was mentioned by Oliver and Don, which is making sure that your testing pool, when you're developing your algorithm, represents the diverse patient population that you're serving. And, you know, we're very proud of the fact, you know, we're a relatively young company. We were founded in 1989. But historically, if you look at our testing pool for the development of our different generation of optical sensors, we've always aimed for a one-to-one relationship between individuals with darker skin tones versus light skin tones, because even in 1989, this was a known issue with pulse oximetry. And so if you look at like all of our historical testing data, we have 49% of our tested population are with patients with darker skin tones. So we're very proud of that, because you know, that's come to light in more recent years, but it's something that we've always had a historical attention to. And I think the same is true, you know, regardless of whether you're talking about an algorithm that's designed for diagnosis or for, you know, audio detection. You know, you really have to take great care to make sure that you're developing and testing and validating on a diverse patient population that you're intended to serve.
100% agree. And we see that in our everyday clinical practice as well. The patients I serve in Seattle are vastly different from the ones I served before moving here. I was in Birmingham, Alabama. Vast differences, both in terms of literature described physiology and symptomatology, like Dawn mentioned, but also in terms of cultural backgrounds and connecting to the patients, and what our patients expect. There's subtle differences in how we build the relationship. So now let's play a game for a second. Let's assume that the four of us are called in by a health system that wants to integrate our AI tool. How, and I would love, maybe we can start with Daniel, and then I would love to hear everyone's thoughts. How are we going to work with the health system to ensure that what we co-create and implement and monitor is scalable? Because maybe we start with, let's say, cardiology, and we pilot something only in cardiology to make sure it works. How do we make sure that it's scalable and it abides by the governance and infrastructure factors to ensure responsible deployment? How do we make sure that it's scalable for the health system? Maybe we start with Daniel.
Sure. Yeah, when I was at the Cleveland Clinic before I joined Masimo, I was involved in building a large, you know, command center type of monitoring system. And when we started that in 2013, we didn't really understand much about implementation science. It turns out it's a whole field into itself. And we just did, like, and I'll just, you know, speak, self-deprecating here. We tried a lot of trial and error types of solutions. Like, okay, we're going to try that. Oh, it didn't work. It's a very inefficient way. I mean, you know, after 10 years of that, we got to where we needed to be, but it was very inefficient. There was a lot of dissatisfied clinicians along the way. And even though we had, you know, some innovative algorithms, we definitely had some really cool technology and a lot of stuff that's ultimately to the benefit of the health system, it was a messy process to get there. I think what I've learned, especially now being on this side of the fence, which is on the medical device industry side, is that there is a really a much more orderly way to do that. And I think, again, there's technical components and then there's clinical components, and the clinical ones I think are 80% of it, and I think 20% is the technical. But just to start with the low-hanging fruit, like medical device integration, interoperability, very, very important. You have to make sure that whatever your new algorithm is, whatever technology you're trying to implement or to integrate, you have to make sure that it can really function in that ecosystem of a hospital where there's a zoo. There's all different types of vendors, and you have to have interoperability, not just with the electronic health systems, but with the other sensors and with the other medical devices that clinicians rely on every day. So that's number one. There are challenges to that, but that's actually the easier of the two. And then the second one is the one I'm referring to, which is the clinician workflows. I think really it's incumbent upon the four of us in this game, in this exercise, to really understand the workflows, understand, the barriers to adoption. And, there's a whole science to this. I mean, there are people that have dedicated their lives to publishing on implementation science and what are the right frameworks and methodologies that you need in order to map out the problem and then make sure that the solution is fit for purpose. So that, the summary of that is that we as clinicians are not bending to the technology or to the algorithm, but that it's bending to us. So it's making our lives easier and better and not the other way around. And I think that's a very important guiding principle for the four of us as we go through this exercise.
Fantastic. Oliver, Don, would love to get your thoughts.
Oliver, would you?
Yeah, sure. So when we founded NOAA Labs, my tech co-founder Marcus and I, we called about 100 cardiologists around the world and did interviews, trying to understand what they want, what it should look like, what they're afraid of, what's not working in their daily practice, really getting this deep kind of understanding of workflows and daily pains. And I think in the coming weeks, we'll do another round of in-person meetings, tens of them, to understand how our solution really needs to work on a daily basis. Because I think that's a mistake many startups make. They develop a technology that might be really, really cool and really helpful even for patients and physicians, but they forget about how it fits into clinical practice. They develop a patient app and a physician dashboard that is accessible online. Got to log into it via browser, which sounds fantastic. But do you want to have 10 browser windows open that you have to switch from one to the next, copy pasting stuff? That doesn't work, right? It's never going to be successful, even if it's a cool technology. So I think having that understanding and developing your solution that way is absolutely crucial.
Absolutely. And just building on both comments that the gentleman had made, I think that adoption is a challenge in healthcare. Healthcare moves slow. We know that. When you talk about AI, it tends to scare people, mostly the IT departments. They're concerned about their patient data. They're concerned about people getting into their systems and so forth. So I think first and foremost, as opposed to being bolt-on solutions, we all have to collectively make sure that security is built from the ground up, right, into our systems. So it's not an afterthought, but it actually becomes part of the foundation. And that's one of the things that we did. We made sure that our systems were SOC 2 Level 2 certified, they're IEC certified, they're all the things that you would need from a HIPAA certification standpoint onwards. Once you get past that, and I think that's just the low bar of entry, then to your point, you have to make sure that you understand the workflow from your physicians and the folks that are going to be using your tools, and not upset that, but actually add to it, right? So it needs to be seamless. One of the words that I think I should have trademarked, but I said we like to try to avoid swivel fatigue. We know that cardiologists and radiologists and all the other clinicians and workflow folks are tired of going from one workstation to the next, one login to the next. So one of the things that we did was we said, well, let's put our information where the eyes of the doctor is. Right. So in the case of a decision support tool, let's make sure that the first image that they see on their PACS monitor is our answer, right? I like to refer to it as the answer key to the test you're about to take, right? So we say AI has evaluated this echocardiogram, and our findings are this patient has a phenotype probability is high for severe aortic stenosis. They meet guidelines. They have diastolic dysfunction meeting guidelines level 2. Whatever those answers are, we present up front. And then the clinician gets to read the study like they normally do. And then when there's those discordant pieces of information that might cause them to pause and might start to second guess, is this severe? Is this moderate? Is it moderate severe? They already have the answer key from AI that's sitting up there at the top, right? First and foremost, without having to go someplace else. And we find that through some blinded studies that actually shows about a 24% increase in the effectiveness of reading the studies and so forth. So that's step one. Then step two, the next part is people have to report on these things. So let's make sure that this is integrated into what the reporting is, so that it's an easy click button that says, yes, I agree with the findings from Echo IQ or from any other system that's out there. And it's a simple click and add, as opposed to now let me log into a different system. So I think the point is, if we're going to be successful in adoption, we need to be on platforms, first of all, where people are existing today. The healthcare doesn't need another workstation. It doesn't need another platform. It doesn't need another logon. So this integration, and we've talked about integration, well, when I still had dark hair and a lot of it for years now. And it's a challenge, and we all understand that. But I think we're getting better. I know from the vendors, and it's not just us, it's everybody, we understand the importance of that. And the more that we can be at the place that the clinicians are and not where we want to be because it's easier, because we have a cool interface, I think we'll be better at adopting our solutions. And at the end of the day, providing the information, because that's all we do, right? None of us are here to replace a doctor, right? To be very clear, we're here to enhance their workflow. We're here to enhance the information that they have so they can make the best diagnosis they can and come up with the right care path and as early as we possibly can. So if we can do that and do that as seamlessly as possible, and I think we'll be all on our way to having large adoption rates and start to change and maybe start to move the needle a little bit in how technology can help and aid in these types of topics.
This is fascinating, and I 100% agree with all of the points all three of you raised. And Don, what a great segue to my next question, which is, let's assume that we have implementation science all figured out and we're great at it. It's going to go great. It's going to scale. How I'm going to start by what Don just mentioned and ask the three of you, how do we make sure that what we offer translates into actionable insights and it's not another tool meant for data collection and analysis and providing another, like it's not merely a detection tool. It's amazing that we can diagnose, it's truly amazing that we can diagnose cardiac dysfunction, valvular heart disease, cardiomyopathies from, the voice or a pulse ox tracing or a single lead EKG or a single echo image, or a still frame or clip or cine. But how do we turn this important information into truly actionable insight for the clinician, into a very seamless, okay, this is what needs to happen right now, and this is how we're going to ensure that it happens so that it directly translates into improved clinical outcomes. Maybe we start with Don.
Sure. I wish I had a definitive answer to this, because this is clearly one of the biggest challenges I think we're all faced with. There's a lot of information. There's a lot. Changing people's behaviors takes time. And to be very candid, it's not going to be done by the four of us. It's not going to be done by a single company. It's going to be done when the industry starts to take a look at this. And understandably, we're a business that says we want to see information. We want to see the data that supports changing how we do things. And part of the challenge that I think we're all faced with is how do we build that evidence so that some of those changes can in fact take place. Again, I apologize for going back to things like aortic stenosis, but one of the things that just came out not too long ago was the FDA said we will now start to allow asymptomatic in guideline patients to receive valves. Right? So that's a step. What we talk about is that valvular disease happens, as we all know, even before it becomes symptomatic and even before it crosses guidelines. So we have evidence that says patients that meet a phenotype as high for severe aortic stenosis have a 5-year outcome that's almost, from a mortality standpoint, almost the same as those that meet guidelines. So we know that these patients left untreated, unfortunately, 50% won't be for their next appointment in 2 years, right? That's just the stark reality of it. It has a worse outcome than a lot of metastatic cancers. But how do we change an industry? How do we change our insurance providers? How do we change folks that says earlier intervention is actually advantageous? And there's a fine balance, and I understand that. There's an economic balance to this. There's also a clinical balance to this. But I think we need to work together, and we need to help fund studies. We need to help gather more information, and it's not just from a singular point of view. I think having the three of us on this call is wonderful because we all address similar problems in a slightly different way. And it's not echocardiograms is the only way to do this, or pulse oximetry is the only way to do this, right? We have to be collective in our thoughts about this. So I would suggest that if we want to make meaningful changes, that we need to be able to support the data, support some of the research that's going to be required that says if we start to intervene earlier, for example, this makes more sense.
Daniel and Oliver, what do you guys think?
Well, I'll go to a real world example because I think you're asking the $1 million question, Effie, which is a good one, and I think the answer starts with, okay, what is the problem that we're trying to solve? Let's not try to I think if you're developing an algorithm, you don't want to tell a clinician something that they already know. You want to try to give them something, an insight into their care, that the care of the patients that they don't have with their existing workflows and with their existing capabilities. And so I'll give you two examples, things quick, that we're working on, and you guys can tell me if we're getting it right or we're getting it wrong, or maybe that audience wants to enter some comments, questions about that. So AFib, let's just take something that we would all agree, like aortic stenosis, big problem, right, globally. And so the way we're thinking about it is we want to tell people stuff that they don't already know. And so we're trying to do that in two ways. One, as the global leader of pulse oximeters, which are used in hospitals every day, we want to use the same type of PPG-based tachograms to tell when patients are in AFib, that exists today on smartwatches and things that are consumer accessible. Apple Watches, others can do that, can say, okay, there's signs of atrial fibrillation here. We want to bring that into the hospital. Because there are patients that are not continuously ECG monitored, but yet are at risk for things like postoperative atrial fibrillation. If we think about like patients undergoing bariatric surgery, diabetics, hypertensive, highly comorbid, obstructive sleep apnea, sleep disorder breathing, obesity, obviously. So those patients can go into post-op AFib. And so you can tell them based on the figure, hey, look, it's like your patient's in AFib, that can guide and inform the clinician to say, okay, I should do either a spot checker or continuous ECG assessment and make that opportunistic diagnosis of atrial fibrillation, which we all know is going to, change their treatment trajectory, hopefully make it less likely they're going to show up in the emergency room with a stroke one day. So that's number one. Number two, when we think about ECG, we spend a lot of time, obviously on different algorithms for AFib detection, which is a relatively mature field. But what about AFib prediction? If you think about a post-cardiac surgical patient, okay, somebody who has a probability of going into AFib of maybe 30, 40%. If we can get a high probability that that patient's going to go into AFib within the next 2 hours, we can give a smart prophylaxis, not giving amiodarone to everybody, but a prophylaxis which is more targeted to a high probability of a disease state. So we're treating the condition before it happens. And so these are two examples of things that we're working on, which we hope are going to be, answers to questions or to solutions to problems that clinicians don't have solutions for today. So that's kind of the approach that we're taking when we think about, the creation of these tools and algorithms.
I think, Daniel, you just made a fantastic point about the predictive capabilities of these new technologies, right? Predicting an AFib event, or in our case, worsening heart failure. And I think what's important here, in order for the physician to have that really as actionable, is not only the alert that pops up or the notification, but it's also the trust in the technology that it actually detects something that would otherwise happen in the future. So you really need to build that trust with your community, I think. And in the medical world, of course, it's obviously a large outcome studies, showing really how you catch patients early, how you make a difference in terms of their path, reducing mortality, reducing costs, or whatever you want to measure. But I think that's what you got to show in order to make things actionable in the end. And there's a second point I'd like to add, and I think that's the usability or the user interface, the kind of how I'm being alerted. How do I make it actionable for someone? So with our technology, we screen the human voice, right, for signs of fluid buildup in CHF patients. And it's something that signals much earlier than the standard of care, like in terms of weight or symptoms. And with the technology, what the model comes up with is a risk score. It's a percentage value, and it could be even more complex. It could be like thousands of features, something a human being could not possibly interpret. So we need a kind of a system that really tells the physician when there's what's the level of urgency. So what we went with is a traffic light system, green, yellow, red. How severe is it? When do I need to act? And of course, behind it is a complex calculation. But I think this kind of transfer needs to happen in order to make it actionable for healthcare providers in the end.
I 100% agree. And we're starting to get some very insightful and thought-provoking questions in our Q&A. The first question is, this is all great, and let's say that we all now live in a world where we can predict when someone is going to get AFib or aortic stenosis or a fast accelerator of aortic stenosis. It was a research study that our group did and published on, or patients with heart failure. We can predict when they're going to get volume overloaded. How do we get reimbursement for this from insurance? Because I think one thing that we are all kind of mentioning but not really saying is that behavior changes when incentives change. And part of the incentive is also coverage and reimbursement and healthcare costs and this whole financial side of the industry that if we touch on today, I think we will need another full hour to talk about. But how do we picture that our relationship with insurers is going to evolve as these tools evolve as well? Maybe we start with Oliver.
Yeah, sure. I think there's two aspects to it. One bottom up and one top down. So bottom up, of course, is the evidence. You always got to show like there is something to your claims. So once again, large outcome studies, really driving hard outcomes the way you want to demonstrate it. And I think the other aspect is more of a legislative or administrative one. So putting in place the kind of reimbursement schemes that favor these kind of technologies, that acknowledge the potential these technologies bear. And I think there are some great examples on some very recent ones. So the AMA put in place this digital medicine coding committee. And what they're working on is proposing coding, for example, for algorithm-based technologies. that help predict events, so future occurrences. And I think that's exactly the right kind of initiatives, the right kind of incentives we need to start thinking about. And there seems to be a lot happening at the moment. Probably still some months, some years needed until it's really enacted. But I think people are realizing the potential of it, especially with the outcome studies.
Daniel, Don, what are your guys' thoughts about?
Yeah, no, I think Oliver said it well. It's outcome studies, but it's also specific types of outcome studies because, you know, in a truly just universe, you know, if you can show improvement in the heart failure outcomes, for example, in your situation, Oliver, you know, getting out front of decompensation and, you know, improving mortality, shortening length of stay, I think that is going to convince clinicians. I think it'll convince guideline committees. But when it comes to payers, it's a different story, you know. So a lot of the outcome studies, you know, that at least we're thinking about in our world are really like focused on cost of care, you know, showing where is the ROI for the payers, where is the ROI for the health system. And so we've got a manuscript which is in publication, because one of the things that comes up in our world a lot, you know, we're talking about non-invasive wearable monitoring solutions in hospitals, is they say, oh, it's going to cost me more to monitor more patients, but our philosophy is, you know, it actually costs you less to monitor everybody. And so what we did in partnership with Dartmouth, and this publication will be coming out shortly in Journal of Patient Safety, is we looked at the outcomes data of all those continuously monitored patients across their med-surg, many of whom just simply, you know, optical sensors alone, you know, not ECG. The ECG was more selective, and showing that there was a benefit in the cost of care that was directly translated to the operating margin for the hospital. So, you know, especially if you look at like models of reimbursement, you know, there's more bundled payments, and that type of model, you show that like anything that you do in the hospital that prevents escalations to higher level of care, you know, additional procedures, those in many payment and reimbursement models, that's going to go directly to the bottom line for the hospital. So if you could show that you can do that, then you make a more compelling case. But it really, you know, the ultimate adjudicator of that is, you know, you're applying for CMS reimbursement, if you know, to private payers, which will follow CMS. But also, I think as a community, as clinicians, you know, through professional societies like the American Heart Association and other professional societies, you know, these things need to be woven into the fabric of clinical practice guidelines, because clinical practice guidelines are very influential, as we saw, you know, in the example of, you know, left atrial appendage occlusion, right? I mean, nowadays, you know, the reimbursement model for that is much more stable. But when we first started doing those, I'm an EP cardiologist, so I know this. You know, when we first started doing those procedures, it was difficult. It took an act of Congress to get that approved. And fortunately, you know, because of all the great science that's been done and all the great collaboration with professional societies that have been done, now, you know, you're looking at a more stable reimbursement you know, model for that. So I think it's just inevitable. It's going to be painful. There's going to be a lot of work that we all have to do collectively to meet those evidentiary thresholds. But ultimately, if we hang in there, you know, there's hope that we can do this.
I could not agree more with you, Daniel and Oliver. I think that when you think about this, it's not a single solution. It's not a single way to approach this. It's going to be all those things, right? We are certainly in front of AMA talking about CPT codes and things like that. And I think that's important because, as we all know, we can talk to clinicians, we can talk to a lot of folks, but when you have that meeting in front of a hospital CFO and he says, well, how do I pay for this? How does this offset and things like that? It's a harder conversation if you say, well, you're going to have patients that show up less in your ER. Right? That's the facts. We know that, right? We know that untreated patients will show up 11 and a half days more in a year. It'll cost the healthcare systems about $6 billion. But when you're having that one-on-one conversation, it's a much more difficult conversation to have. So I think we have to talk about that. We have to talk about I would say the halo revenues that get generated, and not because we're doing more procedures, but because we're doing the right procedures at the right time to the right patient population, right? We talk a lot about ruling in people for care with AI technologies and new technologies, but we can't underestimate and not forget that there's a rule out as well, right? There's a lot of people that are showing up that candidly don't need to go see a structural heart team. They don't need to go anything further than back to their primary care doctor or to a place that'll give them the appropriate care at a much more affordable rate. So I think that we can use the technology and then start to work with the insurance providers and work with CMS and others to talk more in terms of how do we look at population health? How do we start to think about the cost that's associated with certain populations? And what happens if we don't, right? And we can't underestimate that just by delaying treatment, yes, the patient may not have a horrible outcome, but in that 6 months or a year while we're waiting for something to cross over a guideline or a threshold, there's absolutely cardiac damage being done, right? And we don't know the effects of that damage long term on that patient, not only from their quality of life, but then also from the burden onto the healthcare system. So there's a lot more evidence that's required. There's no question about that. But I think we have to have a joint approach, and we have to be talking to the payers about longer term views as opposed to short term. This is for the next year, right? Some of these savings may not happen for 3, 4, 5 years, and that's okay. Sometimes, though, their point of view goes no further than 3 years, right? And that's, I think, the hurdle that we have to get over. But it's something that we all recognize. I know that we'll be out in Chicago in September in front of the AMA again, and I know it's a sold out show already. So we're not the only ones out there talking about this. So.
And I know that we're going to be looking forward to the outcomes of those discussions, Dawn. And we have one more question in the Q&A box, and it has to do with stroke. And I would love to get, I agree with David's question, which is that we all know that stroke is a huge problem, population health problem worldwide. I would love to hear from you guys, when do you think that stroke is going to start getting more of the attention it deserves? Because all of the tools that we've discussed, pulse oximetry for earlier detection of AFib, echocardiographic imaging, and imaging diagnostics in general for risk stratification, and even voice changes. When do we think that stroke is going to get the spotlight? Maybe we start with Daniel.
Sure.
Because you're EP. So
yeah, it's okay. Yeah, it's great. No, I mean, look, I think the starting point is, like, as cardiologists, I think we have to agree that the brain is the most important organ in the body, so we start there, and I think that, the American Heart Association, as our colleagues at AHA will remind us, it's the heart and the brain. There's a very robust, stroke community within AHA. And so I'm glad that this question came up. And I think for us, as a company, we're best known for pulse oximetry, but we actually have a very robust brain health, brain monitoring platform, which is not just depth of sedation, but, cerebral oximetry, looking at, bilateral ability to detect oxygen desaturation of the brain, and then further break that down in terms of, like, it's oxygenated blood versus deoxygenated blood, which can give you some insight into sort of what's happening peri-procedurally during the procedure. And so, we're really excited. We had a TAVI related study with our platform that shows that, that it can be used, there where there's, some very specific concern about, embolic phenomenon, procedural related stroke. So I think, this is another space for non-invasive, monitoring technologies, audio, image analysis and sensors, which is sort of my world, but I think we're going to have to kind of nibble away at the sandwich here, because, stroke is such a, we know that, there are cardioembolic strokes. There's lots of different mechanisms for stroke. There's hypertensive etiologies, so many. And so I think what we're going to have to do is we'll have to kind of whittle it down And I think there are plenty of examples of that. I mean, heart failure is another good example because there's, as you know, there's so many different etiologies, and the way you treat somebody, with cardiac sarcoid is very, very different than you do, sort of ischemic heart disease. And so I think we really have to map out, this entity and really try to find ways that we can nibble around the edges and hopefully take bigger bites, in some of these categories. We're talking about things like atrial fibrillation, for example. Maybe there's a better way to do it than that, but I think that's the best that I've got.
Maybe one of the things I would suggest to the AHA team is create a panel around stroke, because I'm sure that there are folks that are out there that can absolutely tell you all the wonderful things that are being worked on right now. I know from my past life in the diagnostic space, working at Siemens and Toshiba, now Canon, there's a lot of work in AI technologies with image recognition using MRI technologies and CT and the like. So I have no doubt that there is a lot of work still being done on this, but as Daniel said, the reason for stroke is vast. So you have to figure out, is this ischemic? What is the real reason? What is the real driver? And then how do we build those tools to start to look for some of those things? Going back to some of the things I said early on about creating phenotypes. When we say we create a phenotype, it's not that we create a diagnosis, right? We say somebody has the phenotype for severe AS, and let's call it medium. That doesn't mean moderate AS necessarily. It means that there's a phenotype probability. What that really should be doing is calling attention to the clinician that says there's something wrong, right? It has the phenotype for AS, but it may not be. And then look for something else. Now, more times than not, what we find is that something like cardioamyloidosis or other things like that are also present that weren't thought about, either from this symptomology bias or hemodynamic bias that might have occurred. But the reality is, I think the same thing is true for stroke, right? If we start to build these models that start to detect where there's some abnormalities, and it may not be directly to the thing that we thought we were looking for, but it points to something else, that I think you'll see technologies expand and address, real life critical issues like stroke as well.
I got two thoughts on the stroke issue. Out of Mayo, there's a pretty impressive company called Animana. They do ECG analysis, supported by Dr. Friedman in Psychiatria. And what they were able to show is they were able to predict future AFib events like way in advance. And we're not talking about minutes or hours, but like weeks, months, or potentially even years. So I think that this shows some of the potential that lies in AI technology using existing means like the ECG. Like we've known this for ages, right? But there's so much more information in there that we could harness. So AFib as a contributor to stroke. And another thing I got in mind, and this is not research we've done at NOAA Labs, but others did it in the past. There seems to be some relationship between vocal changes and vessel occlusion. It has not been studied in detail yet. It's still early days. But narrowing arteries, narrowing vessels seem to have an impact on the vocal tract as well. So this could potentially, in the age of AI, also be a road forward.
Can I just inject one? Sorry, I know we're short on time, but what Oliver and Don said got me thinking, and I agree. Paul Friedman's work, I mean, it's incredible. What they're doing, and I think that that ability to really make long forecasts on AFib is extraordinary. So I think opportunistic, screening, but also, one of the things that we went down the road of vasculature and science that I thought about that we're really interested in is cerebral autoregulation. And I've really learned a lot, in my training, cardiology, EP, we didn't spend a lot of time thinking about cerebral autoregulation, for the brain, but it turns out it's very, very important. And I'm surprised as we've gone down this road with our brain platform, like how much variation there is in terms of like whether cerebral autoregulation is impaired or preserved. And like, I think we think about like the guidelines of like the care of a patient with hemorrhagic stroke, for example, they're very specific in terms of like, okay, what are, the blood pressure therapies, what are the targets within, the these certain time frames of how it all kind of assumes that cerebral autoregulation is intact. But what I've learned in some of the work we've done is it's not always present, and when you assume it to be. And so like I think with a lot of like sensors, there's an opportunity to like use that patient as their own control, like what's happening with their physiology, to better customize their care so that they get a better outcome as an N of one, as opposed to like a population level. So I think that's where the algorithms that Oliver's talking about can really apply their sophistication into what we were talking about earlier, which is giving clinicians insight. Like, okay, you can't assume that this patient's autoregulation is intact, because it's not. And that might be a game changer. That might be like a fundamentally different way that you treat that patient within a context of a stroke, as if the autoregulation was intact. So just an example, I think, where some of our capabilities through novel sensors and through AI can give clinicians information that they don't have today, and help debunk some of the assumptions that we make when we're taking care of a patient.
Fantastic. We only have 5 minutes left. I want to end with asking each one of you to take 30 seconds and share. It's just an elevator pitch, and share either the best or worst advice or lesson learned during your career in terms of how can we build a successful startup or company that can answer these questions and reshape the way we deliver care. So either the best or worst that you've ever heard, or advice that was offered to you, or your own personal experience, either worst or best, with respect to how do you build a startup that effectively addresses these problems. We can start with Oliver. 30 seconds. Best or worst?
I think first of all, you really need a mission-driven team that figures out a big challenge and that has the right people in place, really smart and capable people, to solve it with technology. And then I think you really need to engage with clinicians. And I think that's something the Center for Health Technology and Innovation can really help with. At least it has been super helpful for us at NOAA Labs. Like, get it out there, get into conversations, and then iterate with that kind of feedback that you get.
Fantastic. So people and right networks. Don?
I think, first and foremost, you have to make sure that you're solving a problem that needs to be solved. Right? There's a lot of great technology. There's a lot of smart people that can do amazing things. But if it's not a priority for the healthcare systems in general, the traction and the uptake is going to be slow. And in fact, sometimes so slow that great ideas will never see the light of day. So first and foremost, make sure you're solving a problem that people want solved. And then I agree with Oliver. I would say you need to surround yourself with a team that is smart, that can move fast, and there's the old expression, fail fast. I think sometimes as a founder we become in love with our original solution and we don't want to let go. And a lot of times when you're building an organization, what you'll have to do is pivot, right? You may try out and work a hypothesis, and you find out that the problem you thought you were solving isn't the one people want, but you can actually pivot not too far from where your original thought was, and then continue down. And too often founders, especially young and early founders, just become married to the original idea, and they're afraid to let go. So I would say fail fast, let go, and listen to your customers. Don't think that you've got the answers, because you don't. In fact, it's people around you that do.
Fantastic. And Daniel?
Yeah, Don, that's such great advice. It's really eloquently stated. I love that. I'll just add the perspective of somebody who works in a large publicly traded company as opposed to a startup. I think for us, trying to maintain that, like, the hunger and that passion that exists within startups. I think that's really a big focus for us. And as a global company, a global chief medical officer, I'll call upon some advice that was given to me by Ken Stein was global CMO for Boston Scientific, and I don't think he'd mind me quoting him. Some advice he gave me is that number one, remember, nobody hired you for your business. That really, my role is a clinical role within this company, and really focused on that, and really focused on bringing the solutions, not the problems. We really have to, Don said it better than I'm saying it. We really have to solve the problems that are important, those unmet needs in clinical medicine. For those that are, listening or watching this that have a clinical background, I think that's a unique skill set that we earn, at the bedside, with all those decades of care that we put in. It gives us insight, and it gives us an understanding, and also an ability to talk to, as Don stated, our customers, to learn from them. So we really are responsive to that ever-evolving healthcare landscape. So I think that's really sound advice, and I think it's a point that we all need to keep in mind.
Thank you, everyone. Thank you, Daniel, Don, and Oliver, for the conversation and joining us today, for contributing all your experience. Thank you to everyone who joined us and contributed their questions. On behalf of the American Heart Association Center for Health Technology Innovation, thank you. We hope you'll join us for our future webinars as we continue reshaping and innovating the future of healthcare together. Have a wonderful day, everyone.
And thank you. I think
Thank
we
you very
appreciate
much.
your moderation.